this class will learn retinal detachment. Introduction. Retinal detachment refers to the separation of the retina from the underlying retinal pigment epithelium and choroid. Without treatment, many peripheral retina detachment progress to involve the central retina and lead to loss of vision. Retinal detachments are classified as retinotogious if they are the result of a retinal hole or retinal tear, and as non-retinotogious if due to traction or an exclusive process. Retinal detachment can occur either passively, as when a retinal hole or tear allows for an accumulation of fluid between the layers, or actively, as in the case of either vitreous traction or an exclusive process. Separation of the retina from the underlying choroidal circulation results in ischemia, with rapid and progressive photoreceptor degeneration, which leads to loss of vision. Risk factors. Non-traumatic RD is the most common due to posterior vitreous detachment, also called PVD. The risk of RD increases with age and is also higher among persons with myopia or a person of family history of retina detachment. It can be a delayed complication of cataract surgery, other intraocular surgeries, or eye trauma. Risk factors for traction retina detachment include conditions associated with neurovascularization, such as proliferative diabetic retinopathy, vitreal macular traction syndrome, retinopathy of prematurity, or skeletal cell retinopathy. It can also occur in patients who have had pre-floating trauma and have developed a fibrotic transvitreal retinal band that contracts. Clinical presentation. Initial symptoms. Regardless of the cause, patients with retinal detachment present with painless loss of vision in the affected eye due to the separation of the retina from the underlying choroid. In most cases, the patient will experience symptoms of posterior vitreous detachment as well, including floaters and flashes of light. However, retinal detachment can occasionally be asymptomatic. Progression of symptoms. For patients with RD, the rate of progression varies depending upon the size and location of the retinal break and the movement of the eye. As the retinal detachment progresses towards the macula, the size of visual field defect will enlarge in a corresponding fashion. Patients will lose the ability to read once the retinal detachment involves the macula. Diagnosis and evaluation. The diagnosis of retinal detachment is based on history and optometric examination. The examination requires slit lamp biomicroscopy and/or a dilated retina examination, often with scleral depression. A careful 360-degree peripheral retina examination using an indirect ophthalmoscopy also should be performed. Peripheral retina examination allows identification of vitreal retina abnormalities, vitreal retinal areas of abnormal traction, round atrophic holes, or Haswell retina tears. Scleral depression during ophthalmoscopy is a very helpful technique for improving the view of the peripheral retina. Patients should also undergo examination of the fellow eye, as there is a relative high rate of bilateral retinal tears or detachment and an asymptomatic tear or detachment could otherwise be missed. In patients with dense vitreous hemorrhage, use of ambiscan ultrasound is needed to help identify large retinal breaks or retinal detachment. Differential diagnosis. The following differential diagnosis applies to patients with floaters. Idiopathic vitreous floaters are the most common cause of floaters. In addition to PVD and retinal tears, other causes include vitreous hemorrhage, vitreous inflammation, ocular lymphoma, intraocular foreign body, and uveitis. The treatment of retinal detachment. Treatment is dependent on many features, including the type of detachment, whether the patient is symptomatic or not, the extent of the detachment and other patient and clinical factors. For small RD, the goal of treatment is to prevent the detachment from spreading. This is achieved by forming adhesions between the retina and choroid in the air surrounding the tear using laser retinopathy or cryopathy. Large RD requires surgical treatment with the goal of retachment of retina. Options include permanent scleral blunt placement and/or vitreoectomy. Vitreoectomy allows relief of vitreoretinal traction, internal drainage of subretinal fluid, injection of air, expandable gas or oil to maintain the retina in position. Scleral blunting maintains the retina in position, while the choroid retina attention forms by indenting the sclera with a stunted expand in the region of the retinal break. A patient with symptomatic retinal detachment, a giant hole can be seen. We give a vitreoectomy as soon as possible. After surgery, the retina detachment disappeared and vision increased. Summary. Retinal detachment occurs when the multilayer neurociliary retina separates from the underlying retinal pigment epithelium and choroid. Without treatment, many symptomatic retinal detachments progress to involve the entire retina and lead to loss of vision. Retinal detachments are classified as retinagonous traction or an exudative process. Treatment of retina detachment and procedures conditions depends on many features, including the type of detachment, whether the patient is symptomatic, and the extent of the detachment. Okay, that's all for today's lesson. Thank you. See you next time.